Hello and welcome to this episode of our Rhinoplasty for Residents and the Foundations of Facial Plastic Surgery webinar series. We really hope you have a great time watching this show.
Thanks very much, Cam. And thanks everybody for inviting me to come along and talk today, even if it is at 2 o'clock in the morning. My name's David Gillett. I'm a plastic surgeon from Perth. I mainly do facial surgery, both in children and adults, and rhinoplasty is certainly one of my major areas of interest. Our primary aims in rhinoplasty are to achieve a good aesthetic result, a good functional result, and most importantly, a satisfied patient. To achieve a good aesthetic result, we aim to obtain a nose that is straight, symmetric, of an appropriate size and shape for the face. In essence, we want the nose to become less of a distraction on the face, such that it highlights the eyes rather than makes the nose the centerpiece of the face. We also want to achieve a good functional result. Rhinoplasty is the classic form and function surgery, so we need to obtain a good nasal airway which lets the patient sleep with their mouth closed. When I first started doing rhinoplasty, which is now about 25 years ago, I had the belief that if I could achieve a good aesthetic result and a good functional results, that the patients would all be satisfied and happy. Unfortunately, I did find that sometimes patients in whom I did achieve what I considered a good aesthetic and functional results were unsatisfied, and the reverse also happens, that sometimes patients whom don't achieve a good aesthetic result or possibly functional result were nonetheless happy. So this brought up in my mind over the years how I can manage the patients to achieve more satisfied patients. And this is purely my practice. This is the way that I do things, and I'm certainly not suggesting that it's the only way to do it. It's a personal perspective, but for me, it has worked. I'm going to run through today the process from first consultation, second consultation. I'm not going to talk about surgery at all. I'm then going to talk about post-operative care and finish off talking about patient selection. Prior to the first consultation, the process commences. So as soon as the patient rings the rooms, a couple of things happens. One is I do request a GP referral. Patients don't have to do it, but I do prefer that they come with a referral from their general practitioner. They get sent several questionnaires. One of the questionnaires is a general medical questionnaire about medications, allergies, and so on. And they also get sent the nose score, which in Australia has become important now if patients want to claim from the Medicare for the septoplasty component of their surgery. The next thing is the first consultation. So when the patient comes in to see me, there are a couple of things that I think are important. One is that the environment needs to be a quiet, comfortable, relaxed and private environment. There can't be any interruptions. So the staff are instructed that for the 15 to 30 minutes that it takes for that consultation, I can't be disturbed. What we then do is I sit down and I make a point of not sitting opposite the patient. So I sit with the patient at the end of the desk, and so that we can both look at the computer, which is used quite extensively through the process. I start by finding what they like to be called. Do they want to be called by a first name or a nickname or whatever? And I have a brief chat just to sort of to get a feeling for the patient. We then go through the medical questionnaire. So what medications do they take? What allergies do they have? Any health issues that they've had in the past. I then do a psychosocial assessment, which I think is very important, as we know that approximately 30% of patients presenting for a rhinoplasty will have body dysmorphic disorder. And so it is very important that we check that. I use a questionnaire that we're currently in the process of developing called the OSCAR assessment tool. Then I take a thorough history of trauma. In Australia, certainly, patients seem to fracture their noses very often, and most patients can somehow recall an episode in their childhood when they have broken their nose. I sometimes wonder whether they're aware of the fact that if the nose was broken, they can claim from Medicare, but I wouldn't suggest that. I talk about airway problems. Are they able to sleep with their mouth closed? Does the airway vary through the seasons of the year? Have they had previous surgery on their nose? Any orthodontics or extraction? And have they had any orthognathic surgery? The orthognathic surgery in my cohort of patients is an important thing to know in advance, not least importantly that the fact that there may be a plate along the piriform margin that we don't want to discover at the time of surgery. I then ask the patient to stand up, and I go to a full-length mirror in my office. And I ask the patient, what don't you like about your nose? And what would you like me to do to your nose? And I take very careful notes at this point in time so I can determine exactly what it is that the patient is worried about. Usually the patient's concerns and my concerns are the same, but not always. Next, I go on to the examination. I use a plain sheet of paper and I handwrite. I don't use the computer. I handwrite on that. I have a form that's a modification of a form initially developed by Steve Bird in a paper that he wrote called The Dimensional Approach to Rhinoplasty. And on that, I do drawings of exactly what I'm seeing, but I also take key measurements that I use in the planning process. For the examination, I also make sure that I have my various instruments available at the start. So the instruments are fairly simple: a ruler, a caliper, a speculum, and some cophenolcane. Initially, I sit and I look at what the patient is concerned about, and I examine the nose without touching. I then palpate and I then measure the various parameters. I start with a frontal view. I initially do the examination on the patient, so a clinical anthropometry. I look at the midline of the face. And then in the midline of the face, I want to see the tip of the nose. I want to see the philtral column, or the lowest point of Cupid's bow, and the center point of the chin. I then look at directly at a line coming down from the inner canthus, which should go through the alar bases. I also ask the patient to smile, and I like to see the canine tooth just level with the medial limbus of the eye. So I look at those, what I consider to be the three key features from the frontal view in a vertical plane. I then look on the frontal view on a horizontal assessment, and what I want to look at, I want to see the middle third and lower third of the face of similar height, and I measure those also. I then make a measurement from the stomion to the menton, so the position between the lips to the lowest point of the chin. Now that should be 2/3 of the lower facial height. The lower facial height should equal the mid-facial height, and that distance, 2/3 of the facial height, should also be equal to the length of the nose. So the distance from the radix to the tip should equal 2/3 of the mid or lower facial heights. I also look at the alar-columellar relationship as described, I think, by Ronald Gruber. And what I want to see on frontal view is I want to see at the alar margins the appearance of a seagull gently flying, and I don't want to see the alar margins retracted too highly. I also look at the front on the width of the piriform margins. which I think is a key feature for some patients with narrow piriform margins and narrow maxillary arches, can I think have nasal obstruction, but they also have an aesthetic problem related to that reduced maxillary width, which can be fairly easily addressed, and I'll discuss that a little bit later. I then look at the chin point. The chin should be level with a vertical line dropped through the radix. It also can be marked with a line extending from midway down the nasal dorsum, tangential through the lips, and that line should be 3 millimeters roughly anteriorly, but I tend to just use a direct line down from the radix. I also look at the relationship of the radix to the supratarsal fold, which should be at about that level. I look at nasolabial angle, about 95 to 105, and also the columellolabial angle. One of the key measurements that I take is tip projection, and I look at a couple of different things. The tip projection should be 2/3 the length of the nose. 50 to 60% of it should be anterior to a line drawn perpendicular to the natural head position down through the most anterior projection of the upper or lower lip. Projection should also roughly equal the alar base width. I look at the chin and how I measure where the chin should be. Having decided where the chin should be, some patients come in with this as one of their primary objectives. Often they don't, and it needs to be brought to their attention. But often advancing the chin with either a horizontal osteotomy of the mandible or genioplasty or a sagittal split osteotomy can make a major aesthetic difference to the patient. And so the last girl just had a straightforward genioplasty. This girl had to have maxillary and mandibular osteotomies as well. I then look at a worm's eye examination, and I want to see an equilateral triangle. I want to look at the position of the caudal septum, and I want the columellar height to be roughly 2/3 of the height of to the tip of the nose on the worm's eye view. I also look on that view at the difference between alar flaring and increased alar base width, because that will determine whether the patient has an alar cinching type suture if the alar bases themselves are laterally positioned, or a weir wedge reduction if it's alar flaring. I examine the airway. I look at the septum. Is the septum central at the ANS? Is there an anterior septal deflection? Is the septum concave on which side? Are there any perforations? I examine the turbinates, both before and after cofenolcane installation, and I look at both the inferior and the middle turbinates to check for any concabulos. So if there is what I consider to be an enlarged middle turbinate, I get a CT scan, and small ones I manage myself, but the larger ones I refer on for management by one of my ENT colleagues. I then look at the internal valves. So that's the junction between the upper lateral cartilages and the septum. And if this angle is reduced, that causes nasal obstruction. I do a Cottle's test prior to looking within the nose, but I find that the Cottle's test, most patients seem to get an improvement in their airway with the Cottle's test. I then examine the external valve, and any collapse on forced inspiration suggests that there's a problem with the lower lateral cartilages, most commonly in my experience is related to over-resection from previous surgery. I then look at the nasal floor and the width of the piriform opening. If the piriform opening is very narrow, the maxillary arch is also reduced, and what this does, it gives patients a smile whereby a lot of the gum is seen adjacent to the molar teeth, which is an unattractive smile. So an operation known as a surgically assisted rapid maxillary expansion, and you'll see at the top in the center is an expansion device. So what we do is we do a maxillary osteotomy at a default 1 level osteotomy, so just above the teeth, and then we wind out the maxilla to increase the transverse dimensions of the maxilla. This has several benefits. One is that it greatly improves the smile by displaying more of the anterior teeth, but it also widens the floor of the nose, which is often very helpful with the nasal airway. The next thing, in the first consultation, I explain the findings that I've made. So I go through exactly what I've seen, what surgery I think may be able to be of assistance, including risks and what's involved in the post-op period. I then summarize and send the patient on their way. When I send the patient away, they go with some written information regarding the surgery. They go with the costing and further information. They also get photographs at that point in time if they wish to proceed. They're then sent away, and if they want to proceed, they then have to contact the rooms and make a further appointment to see me again. At the second consultation, the first thing, when I send the patients away, I ask them to think very carefully about their nose, and I'll often print out the photographs for them, and they can draw on the photographs. I then do some preliminary morphing on the photographs. So when we meet, we discuss any questions that the patients have got after reading through the literature in our first consultation. I answer the questions, and then I show the patients some morphed images. I stress that the morphing process is to aid communication. And the thing that made me very convinced that this was the way to go with using morphing was when I was building a house some years ago, and the architect did some morphing of the building, and suddenly I could see what he meant. I've been using morphing now for almost 20 years, and I find it invaluable. I've never had a problem with patients after the surgery saying that we didn't achieve what we set out to achieve, but I do stress that the morphing process is to improve communication between the patients and myself. It's to let me know what they want, and it's let them know what I'm aiming for, and that it's not a guarantee of outcome. I also show them an example of a patient from just recently. So I vary these patients, all the time. And I stress that, this is an early post-op one, and I stress that the results are not exactly the same as the morphing. So the morphing, we will not achieve the exact result that's seen in the morphing. The morphing is to assist in communication. I find that the morphing facilitates communication. It creates a shared surgical objective, confirms the goal. One of the things with morphing, though, that I do, I don't like to spend a lot of time doing the morphing with patients, because I think sometimes it gets into, oh, can you take off 0.5 millimeter there or add 0.5 millimeter somewhere else? And I think that's beyond my capabilities as a surgeon. And so I stress to the patients, and it also becomes very time consuming, I stress to the patients that what we try to do is just to make sure that we're both aiming for the same goal. I've tried 3D morphing, and I've found that not as useful for me as the 2D, so I've gone back to 2D. Once I've done the morphing and the discussion, I then either do a consent or reappoint. So if the patient at that point in time is confident, realistic, ready to go, we do the consent. Otherwise, we'll meet again. I never operate on anybody with less than 2 appointments, but it's not infrequently 3 or even 4. After the consultation, after I finish with the patient, then first thing that I do before I see the next patient, I sit down and I write a step-by-step plan for the operation, from incision to final suturing. And I write that on a sticky note, which is scanned and put into the electronic record, but is also attached to the file. So at the time of surgery, the sticky note is up on the wall, as are the photos of the morphing. So I know exactly what I'm aiming. I've got a recipe, as I say to the patients. I go through that recipe, and then I use the photos to confirm that I've achieved what I've set out to do. I'm going to skip over the surgery. The surgery is obviously vitally important. Doesn't matter how good you are at managing patients. If you're not doing good surgery, you're not going to have happy patients. Post-operatively, though, the day after, almost all of my rhinoplasties are day procedures. Rib grafts I keep overnight, but the rest of them I send home. The day after surgery, one of the staff members will call the patients to check that they're okay. That might be the nurse or the practice manager. If there's a problem, I talk to the patients. 2 or 3 days later, they come in to get the packs removed if they've had a septoplasty. I use packs. About 5 to 7 days, they get their sutures out. 7 to 10 days, they get their splint off. A week after the splint comes off, I see them again. 6 weeks after and 1 year after. But one of the key things is if the patient is worried, I will see them as often as they want to see me until they are happy. One of the key factors, I think, in having a lot of satisfied patients is patient selection. So there are certain patients that you should not operate on. One of the things is the concern appropriate for the deformity? So the patient who comes in with a minimal deformity, who is having a major impact on their life and then unable to go out and it's destroying their life, you do have to be concerned. Is the patient realistic? Does the patient understand what the surgery can do and what are they hoping to achieve from the surgery? Does the patient understand you? Do you have a relationship with the patient and are you confident that you can achieve what that patient wants? There are patients to avoid. Keep in mind that 30% of patients that present for a rhinoplasty would fulfill the criteria for a body dysmorphic disorder. Now, the evidence for mild to moderate dysmorphia is that surgery may, in fact, for some of these patients, be helpful. I do like them all to see a psychologist, though, if I do feel that they fulfill the criteria for body dysmorphic disorder. The severe body dysmorphic patients, though, will never benefit from surgery, and they need to be that needs to be explained to them. So we need to be aware of the patient with unrealistic expectations, the body dysmorphic, the single immature male who's obsessive and narcissistic. Beware the depressed, flat or anorexic patient. There's a definite overlap between the obsessive compulsive type disorders and the eating disorders and the body dysmorphic disorders. Multiple past surgeries for a minor problem. The over-demanding, angry or aggressive patient is not going to be any different after surgery. The patient that's overly complimentary is also not a good patient. The patient who can't decide what they want and refuses to commit to the process of making that decision is not a good patient. The patient that you don't connect with, that you don't like, if you don't like the patient, in all likelihood, they don't like you either, so you don't want to operate on them. The other one that every now and then a patient will come in and you think everything's fine, but the secretaries or the nursing staff say that they've been rude and disruptive. That, to my mind, is a big warning sign. If in doubt, I refer the patients to a psychologist, and I have 2 psychologists that I work with on a regular basis. Now, if the patients decide they don't want to go to the psychologist, that's fine. They don't have to go to the psychologist, but they don't come back to see me again until they have. The other thing that I think is important, particularly for younger surgeons starting out, is if you have a patient that you are concerned about, that you think it may be a little bit beyond you, consider referring them on to a senior colleague and take the opportunity to assist with the surgery. That can be an excellent learning opportunity. In summary, how to maximize satisfied patients. You've got to listen and plan very carefully. You've got to set realistic expectations. The surgery needs to be precise, planned, and minimally traumatic. You need good post-op care and support. You need to reassure your patients and spend the time with them. You've got to be honest and realistic. You've got to understand what you can do. You've got to choose the realistic patients. If in doubt, don't. And seek support from mentors. When you have problems, don't hesitate to contact your senior colleagues, because any problem you're having, they've probably been through them before. Now, I hope that is of some value, particularly to the more junior surgeons. Thanks very much.
Sure. David, that was fantastic. I think it's one of the best talks I've heard, just covering the basics like that for somebody who really wants to start rhinoplasty. So thank you so much. I know we've got a couple of guys to work through. So there is a question that's come up from Rodolfo. He would like to know, what kind of system do you use for morphing?
I use a Photoshop and Lightroom. So the images are taken by, I've got one of my staff members is a photographer, so that she takes the photos, they get uploaded into a Lightroom program, and then from the Lightroom, they get transferred just into Photoshop, and I do my morphing in Photoshop. I used to use a special program called Alter Image, but I find that I can do it all in the Photoshop. Awesome.
Okay, I'm going to take one more question here. Dagmawi would like to know, what is your age limit for rhinoplasty, both your youngest and your oldest?
Youngest, 3 months. All of my cleft lip patients get a rhinoplasty. Teenagers, after that, I do cleft rhinoplasty on children at about 6 or 7. But for the standard aesthetic rhinoplasty, the young girl with a hump on her nose, I like her to wait till 15 or 16.
Awesome.
And the oldest patient, certainly I've done some in their 60s. I can't think of any older than 60s though.
Mm-hmm. Fantastic. Wow. David, thank you so much. And thank you for waking up at 2 o'clock in the morning. So please feel free to log off and go and get some rest before you start your week. And thank you very much for being a part of this.
Right. Thank you very much.